We are in Washington, D.C. This is the CRT, Cardiovascular Research Technologies Meeting 2016. And they have a number of interesting presentations here. I am with the presenter of one of them. This is Dr. Alec Vahanian, who is the head of cardiology at Bichat Hospital in Paris, France. You were talking here about percutaneous mitral valve repair versus replacement, and they asked you to decide what will be the dominant procedure. Is that really a question we can answer right now?
I think no. My answer is no, but we will debate and we'll speak about that. No, you have on the one hand valve repair, percutaneous valve repair. You have almost 10 years of experience with the mitral clip device. You have over 30,000 patients treated. You have more than 5 years follow-up on the one hand. On the other hand, you have percutaneous mitral valve replacement, where you do have less than 100 patients, really less than 100, and very limited follow-up. A couple of patients are after 1 year. So it's impossible to do today a solid comparison. What we can consider is drawing lessons from surgery. And surgery did show that both methods are there, and they are some sort of complementary. So it's very difficult to say. I'm quite optimistic, because we are probably on the way to move forward based on evidence. Because this valve repair was evaluated in randomized trial, the ongoing randomized trial. It is done very cautiously and on good scientific grounds, which was not the case, unfortunately, for surgery, where the first randomized trial just appeared a few weeks ago, so a few months ago. Yeah. So I think we are moving nicely. To me, we're probably going to end up with the same sort of combined strategy. On the one hand, we'll probably have percutaneous mitral valve repair, but not in isolation, in combination. We do have the mitral clip. We do have also ring annuloplasty, like Cardioband, and the two of them will work very nicely together. So this will be applied in patients probably at a somewhat earlier stage of the disease, in patients with somewhat less advanced anatomic dysfunction. On the other end of the spectrum, in patients with severe anatomic defaults, or patients very advanced, will probably use more often valve replacement. That's a guess. Huh?
I've heard some concern that because we know valve repair works really well in this setting, is there a concern that eventually we'll end up replacing valves that actually could be repaired?
Well, I think we cannot say that today. Today, what we know is percutaneous. Speaking about percutaneous, that it can be done, that it is very safe. Throughout the board, it is very safe, and it does not suppress MR, but it does improve patient symptoms and provide some sort of remodeling. On the other hand, we want to solve the whole problem by replacing the valve. For sure, putting a transcatheter mitral valve in suppress mitral regurg. That's for sure. It is quite straightforward. It is quite a fast procedure. We've seen during TCT it can be done within 30 minutes. That's very impressive. But there are so many challenges. Right. If you've seen the devices, let's say the less we can say is they are bulky. They are quite difficult to position, difficult to fixate. We do not know exactly about the thrombotic risk. And what we know also is that having perivalvular leak may well create problems. We don't know about durability, and the more complex they are, the more concern we may have as regard durability. So let's say there are advantages on both sides, and these advantages of both sides, carefully evaluate them, and we'll see. To me, my guess is there'll be room for both.
We have probably about 250,000 TAVRs that have been performed over a fairly short period of time. This is a more difficult setting. It's probably not going to be 250,000 in 8 years. What do you think it's going to be before we start seeing some big numbers? 5 years?
What I know is the number of dollars which were invested by companies recently. I heard about billions recently in the last months. Well, that's for sure. We know the numbers. I really do not think that we know the number of patients who might be concerned by this treatment. We need good epidemiological studies in secondary MR, because we put numbers, but they are non-magic numbers, right. And we're really co-op trials, the Mitral affair we are doing, show that the number of patients with secondary MR who still have a lot of symptoms and CVMR despite optimal medical management are less than expected. So let's say we need some good evidence-based epidemiologic study, and then we'll see. Probably we're overestimating the number of candidates. But there are still many.
Maybe 5 to 10 years before it starts getting more widespread use?
Well, 5 years seems a little bit short to me. 5 to 10, you're correct.
Okay.
5 to 10.
This is coming for you from the CRT meeting here in Washington, D.C. We have a variety of different interviews we've done, and please check CardioSource World News Intervention for our coverage of this meeting, where I am the executive editor, Rick McGuire.